Greetings and thank you for joining us for today's webinar, Evidence-Based Physical and Occupational Therapy Treatment, LSVT Big, which is going to be an informational webinar specifically for physical therapy and occupational therapy students and also people that are working in academic settings. Before we get started with today's webinar, we would like to acknowledge our funding support, which has made LSVT Big possible and what it is today. And you can see at the bottom of the slide a number of research grants that have been provided to fund research on LSVT protocols over the years. My name is Laura Gousset. I'm a physical therapist and an LSVT Big certified clinician, and now one of the LSVT Big faculty members and the Chief Clinical Officer of LSVT Big for LSVT Global. I'm happy to be presenting this webinar for you tonight because Parkinson's and treatment of patients with Parkinson's and neurodegenerative diseases is really my passion. I've spent almost the majority of my career working with patients with all sorts of neurological conditions, both in inpatient and outpatient settings. And one of my loves over the years has been learning, and I love sharing new learning with students. And so I'm really glad that you're joining us today for this webinar. I hope that you're going to find it informative and useful as you begin your careers as physical therapy and occupational therapy professionals. The plan for today's webinar is this. We're briefly going to give you an overview of what LSVT Big really is. So we're going to talk about the development, the rationale behind the LSVT protocols, and we'll highlight the research and then describe the practice of LSVT Big as you might have observed yourself in one of your clinical affiliations or field work already. At the end of today's webinar, we're going to spend some time reviewing resources and learning opportunities that are available specifically for physical therapy and occupational therapy students around the world, not only in the United States, but in other countries as well that have PT and OT programs. Do disclose to you that I am an employee of LSVT Global, and I receive both lecture honorarium and travel reimbursement from LSVT Global as a faculty member of the LSVT Big training and certification workshops. The objectives of today's presentation are these. By the end of this webinar, we'd like you to be able to briefly explain advances in neuroscience and the impact that they've made on the field of rehabilitation. You should be able to discuss the development and data on an efficacious speech treatment called LSVT Loud, from which LSVT Big was derived. And lastly, we'd like you to be able to describe the development, data, and exercises that are specific to LSVT Big. Now, many of you in our listening audience, if you're a student today, you probably are between the ages of 20 and 24 years old on average. And so you were actually born during what we call the decade of the brain. And we realize that we have other individuals that are listening to this webinar that have been practicing for many years that remember this term, the decade of the brain. And what we mean by that is that Parkinson's disease has really changed in the way that we approach rehabilitative management of Parkinson's disease over the years. And all of this really started to shift in the 1990s when we started to understand the capacity of the central nervous system to make changes and adapt despite a brain that has disease or damage from a condition such as Parkinson's disease. We call this term activity-dependent neuroplasticity, and it's very exciting to know that through some of the research that we have done, first on animal models and now on human models, that we can really begin to see the dramatic effects that exercise has on the molecular function and structure of the brain. So we now say that it's a stunning time to be in rehabilitation today. If you could take a step back in time to perhaps the 1980s or before, you would step into a world where referrals to physical therapy and occupational therapy for Parkinson's disease were fairly infrequent. The consensus was that it didn't help, and some physicians even initially thought that it might be harmful or counterproductive for patients with conditions such as Parkinson's disease. And so typically patients weren't referred until very late in the disease, or if there was a secondary consequence or adverse effect that happened as the result of Parkinson's disease, such as a fall because of postural instability or freezing, causing an injury, and then that subsequent injury would have been treated by a physical or occupational therapy. Things have changed now a lot today because of this research that we have learned and are continuing to learn over the years. We have not only found that exercise has the ability to make positive changes in the brain called activity-dependent neuroplasticity, but we've been able to really hone that down and find out what are those key principles of exercise, what are those key ingredients that really drive brain change. The summary of all of this research is that we're finding that exercise can improve brain function and may actually slow disease progression. And so our mantra over and over again is exercise is medicine. I tell this to my patients, and I tell this to the clinicians that I train, that take very seriously exercise in the management of Parkinson's disease, because it's very much more complex and more beneficial than just prescribing exercises to improve balance, flexibility, range of motion, strength, aerobic capacity, endurance. Of course, all of those things are very important when we're considering therapeutic exercise regimens to prescribe to people with Parkinson's disease, but that is not the only reason, and maybe not even the primary reason. What we know now is that through this intensive exercise, it has the capacity to change the brain's function. So these are some of the key principles that drive activity-dependent neuroplasticity, and I'm fairly certain that you have already talked about some of these principles in your classrooms, in your university setting. We know that intensity matters. Intensive practice is important for maximal plasticity. And all of these principles that drive activity-dependent neuroplasticity are really quite common sense when you think of yourself learning a new skill, whether it be learning to play a musical instrument or learning to play a sport. And so if you take that example and think about yourself, naturally the more intensively you practice something, the better you're going to get at that. Your brain makes new synapses, actually increases and mapping of certain areas that you're using in your brain as you practice intensively. And the complexity matters. We know that as you improve in a skill, it's necessary to continue to increase the challenge of that skill practice in order to continue to improve your skill. Naturally, if you stayed at level 1 and something became very simple, that really doesn't drive the brain to make any structural changes. Repetition is very important. If you think of yourself in a skill that you maybe were very good at when you were earlier in your life because you practiced it maybe frequently. Maybe you were taking piano lessons and practicing piano every day, but now it's been several years. You lose that skill if you don't continue to practice it on a regular basis. And this is true for our patients as well. Practicing tasks that are meaningful to you, rewarding to you, that you're motivated to do, actually activates the basal ganglia circuitry in the brain. And if you think of Parkinson's disease, naturally you think of this damaged basal ganglia circuitry. So this would be a key ingredient in enhancing activity-dependent neuroplasticity, especially in people with Parkinson's disease. Timing matters. We're finding out in Parkinson's disease and that with the prescription of exercise, the earlier in the Parkinson's disease that we can prescribe exercise, the more potential we have to invoke brain change. And a lot of the research now actually is looking at pre-diagnostic biomarkers, because if we can actually find biomarkers that would determine who is at risk for developing Parkinson's later in life, maybe we can apply an intervention such as intensive exercise to stave off the clinical onset of those first initial motor symptoms of Parkinson's disease. And lastly, specificity matters. In Parkinson's disease, through LSVT Big and LSVT Loud, we're specifically targeting the deficit of hypokinesia in Parkinson's disease. The LSVT programs are very unique because they adhere to all of these principles of neuroplasticity. And what I find is really quite interesting is that the LSVT Loud protocols were developed before the decade of the brain, we say, and before some of this research came out. And so over the years, we've really appreciated that these principles that drive activity-dependent neuroplasticity are reflected in the LSVT Big and LSVT Loud protocols. And we know that that is a key reason why these protocols are so very effective. So today, rehabilitation, speech therapy, physical therapy, and occupational therapy are becoming very much routine parts of management in Parkinson's disease. And very happily, I can say to you that especially in this country, but I should say also in other countries around the world, we're hearing more and more reports from physicians and clinicians and patients that physicians are grasping onto the concept of referring patients to therapy early in their disease and even upon diagnosis, because we know that it's so very important in the long-term management and possibility to slow symptom progression in Parkinson's disease, if not disease progression. And so it's not just pharmacological treatment in isolation or neurosurgical treatment in isolation or therapy treatment in isolation, but really to optimally treat someone with Parkinson's, we want the best pharmacological treatment that they can be provided by their medical team in combination with the most optimal evidence-based speech, physical, and occupational therapy treatment that we know of to date. I want to show you a little bit of a video of a case example. This gentleman we refer to as Bernie. And Bernie is what we would call somewhat of your typical Parkinson's patient. In this video, he was a Hoehn and Yahr stage 3, which is a moderate stage of Parkinson's disease. From school, you've probably learned that it's a 1 to 5 staging scale. And he had already had Parkinson's disease for 14 years at the time of this video. And so the video is going to show you Bernie before LSVT Big and then 4 weeks later after this intensive LSVT Big protocol. The reason he was referred to physical therapy was that he was having increased difficulty with his walking, including some balance problems, beginning to have some falls and some freezing as well. So in this video, it might be choppy for you because of internet connections both on your end and on my end, but on the left side of the screen, you're going to see Bernie pre-LSVT Big, and on the right side of the screen, you're going to see him at the end of his 4 weeks. So I think immediately a few things that you can pick up on are that he's not using his cane any longer. He's walking much faster 4 weeks later with longer steps and bilateral arm swing. You notice that he sailed through the doorway without any freezing episodes happening. He almost starts to freeze in the pre-video. All of this increased speed and amplitude of walking allowed Bernie to walk much farther in the same amount of time. One of the other things that might not be too obvious to you is that nobody is standing beside Bernie cueing him. He's not relying on a laser beam or a metronome or any type of external cueing mechanism. And that's really one of the key things that we strive for through the LSVT protocols, is to train patients intensively and repetitively enough so that they learn a new internal cue to sustain their larger, more normal amplitude use on their own in everyday life. In case you want to see that video more clearly, it is listed on our website under the videos tab along with some other videos. So I'd encourage you to go and see a clearer view of that one. In terms of his objective and subjective outcomes, you can see that he went from falling once or twice a month to no falls, using the cane to not. I think the most impactful improvement was his gait speed. And this is very interesting because in LSVT Big, we do not train speed, we don't cue speed. We really just focus on a singular focus of amplitude, so the size of his movements. And speed is automatically re-regulated as a patient retrains amplitude. So he went from 29% of his age-matched norm for gait velocity to 100% of his age-matched norm, which allowed him to walk much further in the same amount of time. Because of this, it enabled him to be more confident with his mobility so that he could go out to dinner with his friends and family, go out to the movies, improve his walking overall, and go play with his grandchildren. Those were Bernie's goals that were salient and meaningful to him, and those were the ones that he achieved through just a 4-week dose of physical therapy using LSVT Big. I want to give you a little bit of a history of where this came from. One of the first questions that we are often asked is, what does that acronym stand for, LSVT? Well, the L and the S stands for Lee Silverman. She was a woman that had advanced Parkinson's in the late 1980s from Arizona. And at that time, her family's express wish was that if they could only hear and understand her. At that time, speech therapy was deemed to be rather ineffective for people with Parkinson's. It was traditionally delivered in a low dose format, once, perhaps twice a week. There was no real evidence, no research that guided clinicians in how to most effectively treat speech disorders or voice disorders with Parkinson's disease. And because of this, it was treated in a rather unsystematic fashion. At that time, there was a Parkinson's Center in Scottsdale, Arizona called the Lee Silverman Parkinson Center that was funded and developed by her family. And it was rather forward-thinking. People could stay there for a month and receive multidisciplinary care, much like a European model of care. So experts were brought in, and Dr. Lorraine Ramig, who's a speech language pathologist out of Colorado, was brought in to help develop some sort of a speech protocol or speech treatment for these residents that were receiving care at the Lee Silverman Center. Through Dr. Ramig's work there at the Lee Silverman Center, she identified really two aha moments or key things. One was it seemed to be much more effective that patients were seen daily for therapy instead of just once or twice a week as was traditional. There seemed to be more carryover and more improvement from day to day when they were seen more intensively. The other thing that she really learned and discovered was that it was much more effective to have a single target of amplitude, so encouraging patients to speak louder in a very structured way. She found that there was a spread of effect, so many other things improved, like facial expression, articulation, speech intelligibility, respiratory support, and so on. And from those patients that were at the Lee Silverman Center, Dr. Ramig started to collect her pilot data in Scottsdale, Arizona, and started really a series of research studies over the course of her career, studying LSVT Loud, and later we have launched into LSVT Big now. And so it's been over a 25-year journey from invention to scale up. Over the years, there have been over $8 million worth of NIH-funded research that have supported the development and efficacy of the LSVT protocols. In the later years, the research has really focused on dissemination to other neural disorders and increasing the accessibility of this evidence-based and effective treatment to patients around the world through technology, such as the LSVT Loud companion system and eLoud, which is a telehealth application as well. In 2007 was our LSVT Big training and certification workshop launch. And since then, we have trained many clinicians, which I will share with you shortly. So today, LSVT Loud has become the global standard for speech treatment. In Great Britain, if any of you are joining us from Great Britain, LSVT Loud has now been deemed as a treatment that all people with Parkinson's will have the ability to receive. We have trained over 16,000 LSVT Loud certified clinicians in 69 countries around the world. And to date, over 10,000 LSVT Big certified clinicians represented by 38 countries around the world. And so it's very exciting to think about the impact that we can have together on people with Parkinson's around the world. The estimates currently are that there's 4 to 6 million people, and some estimates are even as high as 8 million people globally that have Parkinson's disease. We know that over 1 million people in the United States alone have Parkinson's disease, and that number is rapidly growing due to our aging population and better and earlier diagnostics as well. So I want to tell you a little bit more about the LSVT programs. They're administered in a very intensive way to challenge this impaired system, because remember that intensive practice is one of the key ingredients for making lasting and permanent changes in the brain. Our techniques are specific to Parkinson's specific deficits of bradykinesia and hypokinesia, which is slow movements and small movements that are very specific to Parkinson's disease, and also kinesthetic awareness. And this is very unique to the LSVT protocols. Many other physical therapy and occupational therapy protocols work on different types of exercises to improve balance, postural control, flexibility, and strength, but very few that I know of really address very specifically in a targeted manner this problem with kinesthetic awareness that we're going to talk a little bit more about today. Through the research on LSVT Loud, we discovered that when a person speaks louder, it's more than just a laryngeal event. And you can try this yourself just watching your webinar. If you say something in a very soft voice, like "good morning," not much is required of your system. You can see in the diagram the person doesn't really have to open their mouth much. They don't have to expand their lungs and take a preparatory breath. They don't have to engage their articulators very much. But if you say it in a more healthy loudness of "good morning," some things automatically occur. You open your eyes more, you open your mouth more, you take a preparatory breath, you're engaging your facial muscles and articulators more. And all of those things happen very spontaneously and automatically through one simple cue of talk louder. So this is what a snapshot of an LSVT treatment protocol looks like if you were to go observe one. And if you are on a clinical affiliation or one of your fieldwork times, I would really encourage you to observe an LSVT Loud session if there's one that you can observe by a speech therapist locally, because I think it's a very informative thing to do. So in the first part of the session, they have daily tasks, and these are just really exercises to teach the patient how to rescale that amplitude of motor output. First, they do a sustained ah as long as they can in their healthy, more normal voice, and this is measured with the sound pressure level meter. And then using that same ah, they go as high as they can and as low as they can. And lastly, they work on short functional phrases, and these are phrases that are self-generated by the patient. They're things that the patient says every day in the normal course of their day. So it could be things like "good morning," "what's for dinner," "I'm going to go to work now," whatever they normally say every day. They practice those things over and over and over again, in their louder, more normal voice, so that pretty soon those things start to come out spontaneously, and it helps them to remember to use their louder voice in everyday life. During the second half of the session, it's a very, very important part of the session because it's not only training loudness, but now it's how to implement that loudness into context-specific speaking activities. So these are built in terms of complexity and in terms of vocal endurance as well. On week 1, the person has to state words or phrases that are short and simple, using and sustaining their healthy, louder voice. Week 2, now they have to sustain that healthy, louder voice for a whole sentence. Week 3, they have to read a whole passage. And week 4, it's very complex. Now the patient is expected to sustain that more normal voice during conversation that is off the cuff. Maybe there's distractions, either auditorily in the background, maybe it's a noisy environment, like a TV on, or in a restaurant or a cafeteria. And so it becomes very real world for that patient. One of the things to note with LSVT Loud is that the patient is not asked to yell or shout. They're simply asked to produce enough effort and learn what that effort feels like to talk in a voice that's loud enough to be considered normal. From day 1, the LSVT Loud certified clinician works on achieving calibration with their patients. And this is what this means. Because of that problem with kinesthetic awareness in Parkinson's disease, there's a mismatch between how the person with Parkinson's perceives their motor output or perceives their voice and how others perceive it. So in other words, they actually don't realize just how soft their voice is, and often initially blame it on other people not hearing well. So initially we hear things like, I'm not too soft, my wife needs a hearing aid, and when they are first stimulated to speak in a more normal, more healthy loudness, it feels actually like they're shouting. And so as a clinician, you might hear this from your patients sometimes, that they might say, well, I practice at home, but I feel like I'm so loud. And so for us as physical therapists and occupational therapists, it's good for us to reinforce that they're actually not too loud, that the way that they're talking to you is loud enough. Or conversely, if you think that they're too soft, to remind them to use their louder voice. One of the first randomized control trials that was done on LSVT Loud was published and shown here in a peer-reviewed journal. So you'll see that there are 2 lines. The red line was the LSVT Loud group. That was 4 times per week for 4 weeks. And the target was amplitude or loudness of voice. You can see the blue line on the bottom was a respiratory control group. So they were also seen 4 times per week for 4 weeks, also for 1-hour sessions. But instead of a target of amplitude of voice, they were working on intensive respiratory exercises needed to support a healthier, more normal voice. So 4 weeks was the treatment dosage, but they followed these individuals out for 24 months without any further interventions. On the vertical axis on the left side, you see SPL, sound pressure level rainbow. That's a standardized reading passage, and you can see that there was significant improvement in the LSVT Loud group, and the amount of change or difference between the 2 groups was statistically significant. You can also see that both groups dropped off some, but the LSVT Loud group remained louder at the end of 24 months, which was the end point of the study, and they never did go back to baseline even without further intervention, whereas the respiratory control group did. And so from this study, we really established the fact that amplitude, training amplitude is in fact an effective target in improving the speech and voice in people with Parkinson's disease. Now in real world clinical practice, we see people typically every 6 months for a short bout of therapy called a tune-up. And we do this for both LSVT Loud and LSVT Big. And we believe that this helps to sustain those treatment effects to even a greater level. However, for the purity of this study, just a single dose of the treatment was provided. This little graph just shows the number of studies that have been published over the years that have really documented and established the spread of effects that has occurred as a result of LSVT Loud as a singular target. There have been imaging studies done that have actually shown changes in activation in certain parts of the brain following LSVT Loud, and those will be shared in more detail with you during the training and certification workshop. There's also been improvements in all of these other things that are very important, such as swallowing, facial expression, articulation, the perception of the listener, and so on. So now that you know a little bit about LSVT Loud and how long it's been around and how well established it's been in the literature, you might want to know where LSVT Big came from. So around in the early 2000s, Dr. Cynthia Fox, who was a speech-language pathologist, was working on her PhD alongside a physical therapist by the name of Dr. Becky Farley. And the two of them really collaborated together to discuss LSVT Loud, and they came up with a question of if this is very effective and well established for treating the symptoms of hypokinesia and bradykinesia as they affect the speech motor system, couldn't these same principles be applied to the limb motor system? And so from then, a direct translation was developed from LSVT Loud to LSVT Big. Since then, there's been independent research on LSVT Big, which I'll briefly share with you today as well. The fundamentals of LSVT Big are this. It's a standardized protocol. It's research-based, and it's very specific to people with Parkinson's disease. However, during the training and certification workshop, we really also address the application to other neural disorders as well. We have what we call three main key points or paradigm shifts. The first of these is a singular focus on target. So just like for LSVT Loud, the singular focus is on amplitude of voice. For LSVT Big, it's on bigness. So we're training movement. We're targeting those deficits of hypokinesia and bradykinesia, not to make the patient exaggerate in their movements or too big, but to rescale them up to what should be normal amplitude movement prior to their diagnosis of Parkinson's disease. The mode of intervention is intensive and high effort. So it's an intensive protocol in that the patients are seen 4 times a week for 4 weeks. And within those sessions, we really push our patients to high levels of effort that are safe for every patient. So we're continuing to monitor everything that's important, like heart rate and perceived exertion and respiratory rate. But as much as we can, we're training them in terms of aerobic effort, in terms of motor output with their amplitude, in terms of complexity of training, and many other things. And lastly, we're also working on calibration. Just like Bernie, you want your patients to get to the point where they can rely on an internal cue to regulate more normal amplitude. This isn't easy. It's one of the rationale for intensive training in Parkinson's disease, because we know that Parkinson's disease is not only a motor disorder, but it also is a non-motor disorder as well. Our patients come in with problems with kinesthetic awareness. They don't really realize that their movements are too small or too slow. They have problems with internal cueing, so they forget to use their bigger movements, or they're distracted. They have difficulty sustaining their attention. And there's other neuropsychological changes that increase typically in severity as the disease progresses. And so these are barriers to calibration that we really have to specifically address by treating Parkinson's disease not just as a motor disorder, but also as a non-motor disorder through our physical and occupational therapy interventions. Now, this little diagram is kind of cute. This is a gentleman with Parkinson's disease that perceived himself as shuffling, and after just a 1-hour session of LSVT Big, he perceived himself as already moving quite bigger with his arm swings, his stride length, he's standing up a little bit taller, and so on. And just like with LSVT Loud, we see a spread of effects as well, and you'll see this with your patients once you start delivering LSVT Big to them. Even though you focus on this single target of amplitude, you're going to see changes in posture, balance, strength, range of motion, and many other things that are important for movement and function in everyday life. Our mode of delivery is intensive. I already told you that it's 4 times a week for 4 weeks. That would be considered the minimum dosage that is supported by the literature. And we feel that it's really important to adhere to evidence-based practice. So if we see that specific dosages were researched in the literature, whether it be LSVT Big or others, that we really take seriously those dosages as a key ingredient in achieving the treatment effects. So 16 sessions in 1 month. We have 60-minute sessions, and the patient has daily carryover assignments. So it's very important from the very first session to establish their homework, because our goal is that the patient would sustain their homework every day between bouts of therapy to help maintain their treatment effects much longer, and to also improve their treatment effects during that 1 month of treatment as well. LSVT Big is always delivered in a one-on-one intervention, and it can only be delivered by someone who is certified in LSVT Big as a physical therapist or an occupational therapist, or a PT assistant or an OT assistant as well. Calibration in LSVT Big looks like this. So in LSVT Loud, we said that they don't perceive how soft their voice has become. In LSVT Big, there's a mismatch that we see between their perception of their motor output and how they move and how others perceive it. And countless times that I've seen patients, I videotape them and show them, not to belittle them or demean them, but simply to educate them. And oftentimes they're very stunned that they didn't realize just how small their steps had become, that their arms weren't swinging anymore. And so it's really an awakening for them to realize that, gosh, why didn't I perceive this? Why didn't I feel this? I had no idea how small my world had become. Parkinson's disease is usually insidious in its onset. It progresses slowly. It typically is diagnosed in middle age to later age, and so many people initially just attribute those subtle changes in their gait or their movement to aging. And so it really is a barrier to calibration, and so we try to address that. Sometimes when we first get people moving bigger, they feel like they're moving too big. They feel like they're walking with giant steps or giant arm swings, even though you and I as clinicians think that it looks great, think that it looks quite normal. And so just recognize that if you're treating patients with Parkinson's disease and you get them moving better and you positively reinforce them, they're not likely to walk out the door like that if they perceive and really believe internally that their movements look too big. So that takes a lot of repetition and training and feedback to achieve calibration, but that really is our goal of LSVT Big treatment. So this is just a schematic that looks at what happens in Parkinson's disease. People with Parkinson's disease come in with reduced amplitude of motor output because of those degenerative changes in the brain. And because of this, their movements come out too small and too slow. But because of these kinesthetic awareness problems, there's problems with self-perception. They don't recognize that their movements are too small or too slow. On top of that, we have non-motor features of self-cueing deficits, and so they continue to scale these reduced amplitude movement patterns. And as the disease progression worsens, that cycle just becomes more and more of a vicious cycle. So our way of really attacking that from the neural substrates is to force them to increase their amplitude of motor output. So we force them in not a mean way, but we encourage them and we drive them and we stimulate them, and we're the biggest cheerleaders possible to get them to produce movements that are larger and more normal. We improve their self-perception awareness of how much amplitude is required to produce normal movement through feedback, through carryover assignments, through repetitive practice, through videotaping, many different modalities that we do to improve the self-perception awareness. And then also through repetition, feedback. The patient gradually improves in their ability to self-cue and habitually scale amplitude that's more normal. Here's some of the data on LSVT Big. The randomized control trial that has been published in 2010 in movement disorders is shown here. So 60 patients were randomized, and this came out of Berlin, by the way. 20 were allocated to the LSVT Big group, 20 were to a Nordic walking group, which is considered a traditional form of treatment for people with Parkinson's in Germany, and 20 did a home exercise program group that was specific to their Parkinson's symptoms. There was one treating therapist, Olaf Kaufold, for all groups, and so he exercised quite a bit over the year, seeing all of these 60 patients. You can see that the LSVT Big treatment intervention was 4 weeks. The Nordic Walk intervention was 8 weeks. However, they were each given 16 one-hour sessions of physical therapy or of the treatment intervention. They were just dosed a little bit differently based on those specific typical treatment interventions. The primary outcome variable was the UPDRS motor score. If you haven't studied this yet in school, you'll learn as you learn more on Parkinson's is that it's a disease rating scale, and this part called the motor score, if the score drops or is a lower score, that actually means less disease severity or an improvement in the symptoms, in the motor symptoms. The dashed line on the bottom is the LSVT Big group. The solid line on top is the home exercise program group, and the dotted line is the Nordic walking group. The rater was blinded. You can see at the end of the LSVT Big treatment intervention at 4 weeks, there was a significant drop in the UPDRS motor score. And interestingly, that UPDRS motor score continued to improve even up to 16 weeks, which is the endpoint of the study. And I'm assuming that is because of continued home exercise program by the participants in that group. The ones that were in the Nordic walking group and the home exercise program group actually worsened slightly in their motor score. The amount of change that was shown between the LSVT Big group and those groups was statistically significant. And so it was really quite an exciting study. The UPDRS motor score wasn't the only thing they studied, and during the certification course, we'll tell you some of the other outcome measures that they looked at as well. So we've talked a lot about walking and gross motor tasks and improving amplitude, but think about patients with Parkinson's, and there's many things that are affected, including fine motor tasks as well. So there can be problems with writing, buttoning, teeth brushing, stirring, just to mention a few. Our goal of treatment is still the same, to rescale amplitude so that it's within normal limits. And so we're not teaching them to write excessively big or brush their teeth with huge arm movements, but as therapists, we are training them to do it more normally, even if it feels like those movements are too big to the patient. This is a nice example of generalized improvement in amplitude through an untrained task of writing. So amplitude can be specifically trained, targeted trained, including fine motor tasks like writing, and sometimes it simply improves on its own through some generalizability. On the left side, this patient wrote down things that were difficult for him prior to LSVT Big. So he did this on day 1 during the evaluation. At the end of the 4 weeks, without cueing, the therapist gave him a blank sheet of paper, and she dictated these words to him and said, these are the things that you said were difficult for you. I want you to write them down on your piece of paper, and we're going to rate them again. And he rated them on a rating scale. And so you can see on the right side, even though it was untrained, how much larger and more clear his writing had become just over the course of 4 weeks. Okay, so next let's delve into the LSVT Big treatment protocol. Some of you might have observed the LSVT Big treatment being delivered when you were on one of your clinical rotations or during your field work. And if it was delivered correctly, it was delivered for 4 consecutive days a week for a minimum of 4 weeks. Sometimes patients need additional sessions if they have more advanced Parkinson's or other complicating factors. And we'll address all of that in the certification workshop. So 16 sessions minimum in 1 month, and they're hour-long sessions. On the left side of the screen, you see maximal daily exercise, and there's 7 exercises listed there. The goal of those exercises is to help the patients to learn how to move with larger, more normal movements in all planes: forward, sideways, backwards, transverse plane, and secondarily, these exercises really help to improve other things like balance, range of motion, flexibility, strength, functional endurance, aerobic capacity, and so on, because they're trained very intensively. 8 repetitions is just a general starting point, but those are scaled up or scaled down according to the patient's needs and according to the patient's progress over time as well. We'll look more closely at those in a minute. On the right side of the screen, you see functional component tasks. Those simply are some everyday tasks that the patient already does. For LSVT Loud, I told you that they are asked to choose some phrases that they say every day and practice those repetitively in their more normal voice. For LSVT Big, we pick tasks that they do every day, like sitting to standing, pulling their keys out of their pocket, maybe taking their cell phone out, things that they do often, but in a bigger, more normal way. And the more they practice those, the more those behaviors come automatic. Hierarchy tasks are more complex tasks. These are ones that are meaningful to the patient, so the patient chooses them. For some patients, it's as simple as, I want to be able to get out of bed more efficiently, faster, without my spouse's help, etc. Sometimes for higher functioning patients, it could be something like golfing. Maybe it's a recreational activity that that patient really enjoys doing and brings them good quality of life. So over time, we work on building the complexity so they can sustain their bigness or their normal amplitude during that whole complex task. Lastly, within every treatment session, we incorporate some sort of big walking, and the distance and time may vary. And during our workshop, we will definitely describe how big walking applies to occupational therapy and physical therapy, and how that can be different depending on your discipline. Here's a snapshot of the exercises, and I'm not going to play videos because the video playback typically isn't very good, high quality during our webinars. But you'll see Jenny here doing 2 sustained exercises, and in this exercise, there are movements where she moves in her body in different directions. For example, in the floor to ceiling, she reaches forward, down to the floor, she reaches up, and then she holds this big posture for a minimum count of 10. On the other one, you can see that she does a big reach across her body and holds it to the side for a count of 10. So there's a couple of really important points about these sustained movements. One, that you can see that they produce some dynamic stretching, but they also help to improve the ability to really hold that big posture, so improve postural control in sitting and also in standing then as well, we hope, over time. After this, the exercises are repetitive movements in different directions. So you can see Jenny doing a forward step, a sideways step, and a backward step. So this person is working on directional changes, starting and stopping movements, completion of movements, and all of those key things that are typically challenging for people with Parkinson's. Think about regular everyday functional activities and you'll realize that whatever you do during the day requires movement in all planes and all directions. And so over time we increase the complexity of those exercises for patients as they improve, or for patients that are early in their Parkinson's disease. And for patients that are lower functioning, we often adapt them by giving them more upper extremity support and even adapting them to different positions such as supine or seated. So although it's a standardized protocol, there are many ways that we can customize the delivery of this treatment to the needs and goals of each person. The last two exercises are rocking and reaching exercises. And so in these, Jenny isn't moving her feet in a stepping fashion, but it's a rocking motion forward and back and more of a twisting motion from side to side. And so really these are all very functional movements. But they're not the end-all and be-all for our patients. We recognize that there's a million exercises out there that you could choose, and these exercises aren't necessarily magical. But what is very important is that the patient not only learns how to generate increased motor output and move bigger, but then they realize how to incorporate that bigger movement into everyday function. And this is where it becomes really very, very important for our patients. So it's not the end goal of therapy. You can see this little snapshot here of Jenny doing a rocking and reaching exercise, but very similar to this lady taking big steps and swinging her arm as she's walking her dog. And so for your patient, then the exercises have much more meaning if they recognize that, you know what, this specific exercise really simulates what I do with this other functional activity that's part of my everyday life. And so that becomes very motivating for the patient and helps them to be motivated to do their exercises long term. The next part of this treatment session is called functional component tasks, and those are patient driven. So that means that we really sit down, we get to know our patient, and we want to know what are the things that are difficult for you, what are the things that are important to you, what are the things that you either want to improve upon or maintain despite the progression of Parkinson's disease that will continue. So there's simple motoric tasks. Our patients have 5 of them. These are just some examples. Sit to stand is one that we train all of our patients, and it's probably the most fun one to train as well. Many patients, even my advanced Parkinson's patients, can be trained to generate larger amplitude to get out of a chair without rocking, without needing to use the armrest, without needing someone to give them a boost up out of the chair. Because they're not generally weak, they generally are just not doing that forward weight shift big enough. These functional component movements become mental sticky notes. So we want to help patients do them repetitively enough so that every time they get out of that chair, it's a mental trigger that says, oh yes, I remember I have to use my bigger movements. And so that helps to address those internal cueing problems that happen with Parkinson's disease. The hierarchy tasks are more complex tasks. Just like the functional component tasks, they're complex. They're patient-driven. These are just some examples. They vary from patient to patient depending on their goals, their needs, and you can see that there's a range of activities given as examples here that would fit with people that are both early in their Parkinson's disease or later in their Parkinson's disease. During that hierarchy task, we break it down into subtasks, and we just go back to your motor learning schoolwork and think about blocked practice, moving into sequential practice, and eventually random practice. And that's really how we deliver the hierarchy training in LSVT Big. So these are just an example of maybe week 1. If the hierarchy task was preparing a meal, we would do blocked practice of each of these activities on their own, perhaps simulating it at first and maybe later on in the treatment protocol with actual tools or objects that they would use in real life. And week 2, we would practice the sequence of those activities, and by the end, we would hope that that patient could practice that whole activity, keeping their movements normal, healthy amplitude. Maybe they're talking, maybe the TV is on in the background, just as they would in their home environment. So our goal is always calibration. We expect our patient to self-critique. We want them to be the ones engaged in problem solving and sensory processing. Initially, we give them lots of feedback, feedback just in verbal cues, and also videotaping feedback as well. And by the end, our patients are really saying things to us such as, you know, let me go back and do that again. I think I could be a little bit bigger next time. And so it's really a fascinating process to see patients developing that skill over time. Throughout every session, we work on big walking. Again, we're not working on walking that's exaggerated, but we're driving them to produce bigger arm swings, bigger steps in all sorts of environments so that they can sustain and generalize that more normal walking to all sorts of settings, whether it be their really crowded tiny apartment at home so they can walk without freezing, and get to the bathroom efficiently, or if they need to go on a shopping trip or an excursion where they're going to have to sustain their bigger walking for a longer period of time in a more complex environment, etc. So to our patients, it kind of feels awkward at first, and if it doesn't, they're usually not walking big enough. Likewise, over time, it becomes more natural for our patients. It doesn't always feel too big to them typically. At the end of every treatment protocol, we assign patients carryover exercises, and this is really where we mandate that patients use their bigger movements in a novel way every day in real life. Because we want them to not just move big in the treatment room, we really want to push them to get out and experience use of those bigger movements in the real world and have positive reinforcement of those. That really helps to break down that barrier that they feel those movements are too big when they get that positive feedback. So just like the hierarchy activities, we progress those in difficulties over the 4 weeks of treatment as well. Here's an example. Keep it simple for week 1. When you leave the clinic, you're going to walk to your car with your spouse. You're going to walk big enough that he or she comments about your walking. When the patient comes in the next day, that's the first thing we're going to ask them about. How did it go? What kind of feedback did you get? How did it feel? Week 3, we're going to expect a lot more out of our patient. It might be something like when you go to a restaurant today with your family, I want you to open the door big for someone, walk to your table big, and sit down with your big posture. And use your big posture when you order your meal and sit through dinner. So now they're having to not only use their big movements in a more complex environment with more people around, but they have to sustain their bigger movement for a longer period of time as well. Our treatment goal for LSVT Big is we want our patients to use their bigger movements automatically in everyday living, and we expect that there's going to be long-term carryover of increased amplitude use. So in summary, I hope this webinar was helpful to you tonight. We did describe those advances in neuroscience that have provided neurobiological and behavioral evidence supporting the positive impact of exercise-based protocols in people with Parkinson's disease. You know that there's a rapidly growing literature body in physical and occupational therapy exercise protocols in humans with Parkinson's disease, and the LSVT Big programs and Loud programs have been developed and studied over the past 20 years. LSVT Big is one type of physical and occupational therapy program that really does have potential to offer improvements in movement and quality of life with people with Parkinson's disease. So now that you've heard a little bit about LSVT Big, I just want to go over some information on resources and training options for physical and occupational therapy students. The first one is group online training. It's possible that you belong to a university that has interest in having multiple students trained in LSVT Big. And we have an online training and certification workshop that is exactly the same as the live training and certification workshop. And what many universities are doing now is offering this in a classroom environment or in a group environment to their students. So what that looks like is that the students might come together in the classroom with their laptops. One of the faculty members possibly would facilitate it. And during the times within the online training where there's practice required, you would move to your lab and practice exercises, perhaps even bringing in volunteers with Parkinson's disease, etc. So there's been many really interesting and effective learning models that different universities have used in this last year. Some are completing the individual online learning on their own and then gathering together at the end for a question and answer time and a lab practice time. So if this is of interest to you and offering this to multiple students in your PT or OT programs, please email us at training@lsvtglobal.com. Group discounts apply if there's 5 or more students. For students, it's really a great time to get trained because not only does it give you a foundation in evidence-based practice for Parkinson's disease that you can use on your clinicals during school or as you graduate, but financially it's a good investment as well because the professional certification is more expensive than the student training and certification. There's faculty discounts as well. The other option for you, maybe you are one that is an eager beaver and doesn't want to wait for a group training opportunity to be developed in your university. So please note that you can get trained online anytime. If you go to our website, you can register online and you will see that there's a registration link just for students. What's nice about the online training for students that I've received feedback from is that it's so convenient. You can fit it into your schedule. It's paced out over 90 days, so you can self-pace it any way you want, and you can start anytime that you want. And so it really is flexible and convenient and has cost savings for students in the registration fee and also in the fact that you wouldn't have to pay travel expenses associated with the live workshop. The other thing I wanted to tell you about the online LSVT Big course is that it is parallel content to the live workshop. We've studied the competence of our learners both through examination and physical performance, and it's the same as learners that attend live workshop. All the materials are downloadable, but their physical materials are shipped to you as well. Since inception, we've had over 1,000 learners already complete the online LSVT Big training and certification course. So the other option for you is to attend an in-person LSVT Big training and certification workshop. We have courses held throughout the United States, and you can always find these by going to our website, lsvtglobal.com, and clicking on LSVT Big to find the LSVT workshops that might be coming to your area. The workshops are always 2-day workshops. They're typically weekend workshops. That content is parallel to the online workshop. And we do have a limited number of student spots available. So if you're interested in this, sign up earlier rather than later for a live workshop. The registration fee is the same. It's $300 per student, or a group rate would be $275. So here's some instructions just for your reference on how to get started with LSVT Big training. Here's the registration link, and you just click on Online Student LSVT Big Certification Course. For in-person LSVT Big, here are the directions as well to get to that link. And if you would like to learn more about setting up an online LSVT Big training at your university, please email either training@ or info@lsvtglobal.com. And I'm actually the one that helps to facilitate and set up those online trainings, and so I'd really be excited to talk with you more if you're interested in that. Some post-training information, some FAQs that you might be wondering about. If you get certified as a student, you can use LSVT Big, but it has to be under the supervision of an LSVT Big certified clinical instructor in accordance with state and federal practice regulations pertaining to students providing hands-on care to patients. After you graduate, contact LSVT Global and we'll upgrade you to professional status for free so that you can be listed on the website and receive referrals. Your LSVT Big certification renewal is due every 2 years, and that's based upon your certification date. It's a short 2-hour online module. It's $50, and the purpose of the certification renewal is to really keep you up to date on the latest as we learn more about delivery of LSVT Big and as we develop more as well. Some research opportunities that you might be very excited about this year. If you're still going to be in school next year, or if you're a university faculty member, please note that we have small student grants available for the coming school year. So we'll be awarding 2 $1,500 grants each for PT and OT students. It has to be treatment research on people with neurological conditions, but the treatment intervention does not have to be on LSVT Big. You can email Geraldine Schultz, our grant manager, for more information, or download our call for proposals from our website, or email us and we can send that to you as well. If you're a student and you're interested in participating in treatment research on LSVT Big, please note that you must also be certified in LSVT Big and have treated at least 3 patients if you are the treating clinician in those studies. So here's how to learn more. If you would like to find a clinician in your area who is LSVT Big certified, we have a clinician search tool on the home page of the website. You can find it geographically by putting in your zip code or your country code of where you live. It's a nice opportunity for students to observe or shadow someone who is delivering LSVT Big if you have the opportunity to do so. If you're interested in joining us for other upcoming live webinars or viewing any of our previous recorded webinars that are free on demand, please follow the link, patient resources, and then free on-demand webinars or free live webinars. And lastly, we do have DVDs available to introduce you to the exercises that we use in LSVT Big and in LSVT Loud, shown via the links here. Those are helpful homework helper videos that many patients use to support their home practice both during the 4-week protocol and after they complete the 4-week protocol. Here's just a listing of our public webinars coming up in the first part of 2016 that you might be interested in. And over as the year goes on, we'll be adding more webinars to that as well. If you're in the area of any of these cities, Chicago, Berlin, or Portland, we'd love to come to meet you. The AOTA annual conference is just around the corner in April in Chicago. So if you're an OT student or OT or faculty member who's going to be coming to AOTA, our booth is 512 or 5112, and we'd love to meet you. The International Congress of Parkinson's Disease and Movement Disorders is coming to Berlin, and we'll have not only posters there, but we'll have a booth there and pre-conference LSVT Big and LSVT Loud courses. So for our international listeners today, please join us if you are attending that wonderful Congress. The World Parkinson's Congress is another very exciting opportunity in Portland, Oregon, September. This is an event that's not only for healthcare professionals, but also attended by people with Parkinson's disease. And prior to that Congress, we'll be hosting LSVT Loud and LSVT Big live workshops as well. And lastly, the American Congress of Rehabilitation Medicine is having their annual conference in Chicago in November and late October, and we'll have both a booth there and presentations that we'll be giving. So please join us. There are many opportunities for you to learn more about Parkinson's disease through these organizations. There are also many different Parkinson's community events, and so there's opportunities for you to learn more from the patient perspective, to be an advocate, and LSVT Global also supports these organizations, the Victory Summit and the Michael J. Fox Foundation's Partners in Parkinson's events as well. They happen all over the United States and Canada, and here are the upcoming dates. And so if you are interested in attending, you sure can. And for certain, if you know people in your community that have Parkinson's, please encourage them to attend these wonderful events. With that, I leave you with a quote, and this quote came from a woman named Sharon Ka, who is living today with Parkinson's disease, and Sharon is amazing. There are many videos of her that you can find on the internet, and she has gone through both LSVT Big and LSVT Loud, and she's very inspiring and motivating, and she really wants to share this quote with you and with other people that have Parkinson's disease, that it is possible to take charge of your life even with Parkinson's, and it is possible for your will to override your brain, and so it is possible to have power over Parkinson's. That is really the message that we want to share with our patients, and that is the message that we want to share with you, because you as students are so very important. You are our future of our professions. You're going to be our movers and shakers and our leaders, and you will have the power and the ability to propel on further improvements in research and treatment options for people with Parkinson's over the course of your years. And you will certainly impact many, many people with Parkinson's disease if you do go on to receive specific training like LSVT Big. So thank you for joining us tonight. We hope that this webinar was quite helpful to you and informative to you. If you have questions, please email us anytime at info@lsvtglobal.com, and we're really happy to answer any questions that you might have, not only on this webinar, but even other general questions that you might have. So if there is a survey that pops up at this end of this webinar, please do fill that out. We really value your feedback, and we value also your ideas for future webinar topics that might be of interest to you. So with that, I thank you for joining us tonight. I hope that you all have a wonderful evening or rest of your day.